I asked Tane Peckett to be in the room here. I wanted to explain to Tane, who's the only guy I know that owns a Hummer, that I meant that is it the SUV of end-stage lung therapy as a pejorative thing. I meant that to be a bad thing, Tane. So anyway, well, we're going to hear about both bilateral and single lung transplantation. It's not a debate, and we chatted for the first time about this just a few minutes ago, and I think that we'll cover different aspects and maybe even come up to with different conclusions. The evolution of the whole lung transplant operations or selection of procedures roughly goes along this chronological curve, with single lung transplantation really being the first successful model. Double lung transplant, which is what I call an abandoned operation with the tracheal anastomosis, was shown to be an awkward operation to do and also very fraught with complications and death due to poor healing of the trachea. It was quickly replaced by bilateral sequential, which has now become what we would refer to as a double or bilateral lung transplant. And then some little twists on bilateral lung transplant, in which a single lung might be split and used on both sides, or two different lower lobes from donors would be used to prevent or create a bilateral replacement for a single recipient. When I think of bilateral lung transplantation, there are a few indications, or a couple indications, where it is mandatory. And this is a collection of 18 years of experience at WashU, about 900 cases. And cystic fibrosis was 151 bilaterals and no singles. Bronchiectasis, 21 bilaterals, no singles. Every other indication is probably pretty reasonably well represented by either operation, which would suggest that, that either operation is commonly used or perhaps appropriate. Lately, we've been pretty much a bilateral lung transplant program with maybe one or at most 2 out of 50 transplants per year being single lung transplants. And it's quite annoying when you actually do one, because everybody asks you over and over again why you only did one. And so it's come to be an expectation at our center that a bilateral lung transplant is the default operation. And some of this data might raise questions as to why that is so easily accepted. There's a lot of different yardsticks or rulers you can use to compare operations for lung replacement. And these are just a few. Crude survival is the easiest, but probably the most fraught with bias. Risk-adjusted survival takes into account some of the complexities of the recipient prior to the transplant operation. Quality of life is probably under-studied measure that would help distinguish the outcomes between single and bilateral lung transplant. And if you use the quality of life to adjust the survival, now you're sort of honing in on perhaps the measure that we ought to be focusing in on most. And then cost effectiveness wraps together both the quality adjusted survival and the costs, if you can decide on what the true costs really are. And when I reviewed the literature about lung transplantation for this presentation, some general themes I could mention: that it's very common and easy to compare single to bilateral. And so almost all big papers seem to work a comparison in. So there's a lot of information for both John and I to draw on to convey. There's a lot of inconsistent use of risk adjustment, although the more recent papers, and what I would think are the better papers, definitely acknowledge the risk of the recipient. Almost all of them recognize that an emphysema patient and an IPF patient are going to be different entities and might have a different correct answer. And then there's pretty rare use of quality adjusted life years or cost effectiveness in the purest sense. Just to start with emphysema, that's the diagnosis that has really been what I got trained with. We did more than half of our transplants at that time for emphysema. And I'll just come through some of the different types of studies with different various levels of adjustment and I think thoroughness. And I'll begin with one that summarized some data that took place before I got to WashU. It was the first 119 transplants for emphysema. and they were comparing bilateral for single and found that the 90-day mortality was similar and that the 5-year survival, although 53% versus 41% of 5-year survival seems substantially different. The study was small enough that it was described as simply a trend, and there was really no adjustments for any other risk factors such as age or associated pulmonary hypertension or other things that might impact the survival. We continued to accrue patients, and that was 119 patients, and this is when the number of emphysema patients a couple of years ago got up over the 300 range, and what we saw was a pretty distinct parting of the curves. This is, again, an unadjusted survival curve, but it has led to our conclusion that bilateral lung transplantation is probably better for COPD or emphysema than single lung transplantation. But our own experience and my own personal habits, and I think those of the other transplanting surgeons over the years at WashU, has been that for many years, and the single lung transplant recipients for emphysema generally have had a reason to get a single lung. And maybe there have been some issue on the other side that would have made it a more challenging or difficult operation, or perhaps the age or general fitness of the recipient led to a lesser operation. And so there's a bias that went into these parting curves at 3 years, where we gave more lung to the patients that we thought would do better with the lung. A similar study that is not adjusted but came up with perhaps a different conclusion is from University of Pennsylvania. 120 some patients with 2/3 getting a single lung transplantation and 1/3 getting bilateral. The single lung patients were older, which is something that I think would ring true in most centers, and more likely to be female for reasons I don't understand completely. But the 5-year survival was actually quite good for both, 57% for single and 62% for bilateral, and functional difference was noted, both better forced vital capacity and 6-minute walk test in the bilateral. And inexplicably, they concluded that the single lung transplant is the operation of choice. And that conclusion, I thought, was very loosely based on the data that was presented, and it was more a result of the lack of a substantial difference and the better utilization of a limited resource of donor lungs, if you read the conclusion of the paper. So it really, it's kind of ambivalent data and a conclusion that probably could have gone either way. Probably one of the better or best studies that tries to wrap in all the elements of adjustment that I talked about is this one. It's just from last year in Lancet, and it was a huge number of patients. So a little more than 1/3 got bilateral transplants for emphysema, 2/3 got single lung transplants, and they did propensity matching to adjust for the risk associated with an individual recipient, and found an overall survival mean of 5 years, which really fits with what we see in a lot of single center and database results. And saw a substantial difference in the survival in bilateral recipients over single recipients after adjusting for the differences in those recipients prior to transplant. However, they throw in the caveat that there didn't appear to be a benefit, or at least a much smaller benefit, in recipients who were over the age of 60. Now, I won't go through all the different diagnoses, but just to kind of recap what I think is an ascendant diagnosis, now that we have the lung allocation score and the sicker patients are getting priority, we're all seeing a lot more pulmonary fibrosis, and I think that there's a similar equipoise or ambivalence in the field about which is the right operation for the pulmonary fibrotic patients. In a paper that I presented and analyzed at a time when my comprehension of adjusting and propensity analysis was 0, we just did a straight-ahead comparison of bilateral and single at WashU, and found that there was no difference between our single or bilateral transplants for pulmonary fibrosis. And in a unadjusted comparison using a large number of patients from UNOS, there was also no survival difference between single and bilateral in this paper from 2003. On the other hand, there have been papers that have shown a difference, and a very well constructed paper from Cleveland Clinic using all the bells and whistles that Eugene Blackstone can throw at a paper